Thank you very much. The idea of this session really is just to provide a few different practical the power to go about this kind of technique. This largely based on their experience, I'm showing the journey like some of the challenges I can way. Clinics. I'm the head of medical for Can I Help, and I just want to share some of the journey that we've been on and some of the systems that we've set up there. So it'd be very informal. I know it's probably not the way things are done, but if anyone wants to just ask questions as they go along, that would be great. I'd rather do it that way. And then we'll have hopefully a bit of time for that at the end as well. So I moved to Australia from the UK in 2018. These were the headlines. So these are from the UK Guardian, and these were published about a month before I moved across. So at that stage in the UK, all cannabinoids were completely illegal. And these are two high-profile cases of kids with epilepsy who've been treated with CBD products in the US, and their parents had been arrested as they landed in Heathrow Airport. Their CBD had been confiscated, and they went on to, having had their seizures very well controlled, they both went on to be admitted to hospital with uncontrolled seizures within a week of landing. And it was these couple of high-profile cases that really changed the landscape within the UK. But needless to say, you know, I came across to Australia with absolutely no prior knowledge of cannabinoid medicine at all. It didn't feature in the curriculum I was taught whatsoever, other than just you know, that this was a drug of abuse with no medicinal properties. So it was quite a journey for me. So my background as a GP, and I ran a group of general practice clinics in the UK and did some teaching, and also commissioned some health services in the UK as part of the National Health Service there. When within 6 months really of practicing in Australia, I found that a lot of patients were coming to me and asking me, did I think that medical cannabis would be an appropriate therapy for the problems they were having? And you know, that was often chronic pain or anxiety or post-traumatic stress. And to begin with, my standard answer was, I don't really know. I've not really got any experience in medical cannabis. I'm very happy for you to explore it. I'll refer you off to to another clinic where they can assess you and look at that. And what happened is those patients then returned to see me, and I was extremely impressed with the results that those patients were achieving on medical cannabis. There were patients that I'd made little or no progress with in months who seemed to be getting an awful lot better. I saw people who'd been almost housebound from their anxiety, beginning to get out and to do things. I saw people with chronic pain where their mobility had improved a lot. And so I was extremely impressed with cannabis as a therapy. What I wasn't impressed with at all was the clinics that they were going to. I got a lot of these clinics I referred to, I got no correspondence back whatsoever. And the patients gave me stories about how they been charged for a consult, then charged an admin fee, then charged a prescription fee. And it seemed to be that the patients were hemorrhaging cash to these clinics. And so, look, I decided I was going to start doing it myself. I got myself trained up, I went on some courses, and I started prescribing for my own patients. And then within the course of about 3 months, the other GPs in my clinic started referring me patients. GPs in the locality started referring me patients. And the cannabis supplier that I was prescribing started referring patients as well. And the whole thing absolutely ballooned. And there were a lot of issues I was having in terms of running that clinic within the general practice surgery I was working in. And so I did that for a few months, and then went on, after about a year to set up Can I Help? So look, I wanted to focus on what were the problems I had as a medical cannabis prescriber inside a general practice clinic. So I've listed them there on the slide, but essentially patient selection was one of my primary ones. I'd have patients that would get booked in by our reception team who were unsuitable, who hadn't gone through first-line therapies, who didn't have the right conditions. It was then very difficult, having booked a long slot to do them, to kind of turn them away. For patients that came outside the clinic, we had no mechanisms for getting their background information, for getting their consent to contact their regular doctor. The TG applications were taking me forever, not just filling them in, but then getting the approvals back, collating them with the prescriptions. I had no mechanism for getting written consent when I was doing a telehealth consultation, other than emailing a form and getting them to print it and sign it and scan it back to me. Writing clinic letters to their regular doctor was taking forever. I had no method of measuring the outcomes using questionnaires. And then there were the problems that I'd prescribe a product that would go out of stock, and then I'd have endless phone calls from the pharmacy saying, oh, what alternative can we give them? What do you want to prescribe instead? And then just keeping up to date with all of the medicines that were out there and, knowing about them. There were no formularies of products that were available. The patients would often come in saying, I've researched this one online and I'd know nothing about it. And so, look, I think it's fair to say that running this as a solo practitioner within a GP clinic was really quite difficult for those reasons. And so kind of what I decided was actually that model was just not a good model for providing high quality cannabis care. And so I went and set up Can I Help to try and overcome that. So when I was commissioning services in the national health system in the UK, we always talked about the three things you'd want from a health service were accessibility, affordability, and quality. And the traditional teaching there from the commissioners that I worked with was you pick the two that you wanted because it was impossible to achieve three. And when we think of examples of health systems within Australia, we can see the public system probably provides quality and affordability, but the accessibility is terrible. A lot of private clinics provide good quality and reasonable accessibility, but they're unaffordable for most people. And so I think there's a lot of truth to that. But I decided with Can I Help, I really wanted to do my very best to try and achieve all three. So I'll just unpack what I mean by those. So what is quality? And this is a personal definition I've got here, because there are no quality standards for cannabis clinics in Australia. There are no guidelines that we're working to. There is no accreditation. At the minute, we're in the industry, we're at the stage where this is all self-police. But I guess what I mean by quality is the patient sees a doctor who's well-trained, who knows about cannabis and keeps up to date. I believe the doctor should take a patient-centered approach to the care that they're providing. I believe it's important that we communicate with other providers. So, we make contact with the patient's regular GP to obtain the background. We write to specialists, we write to other GPs. We try and inform the other providers about what's going on. And that seems to be something that's relatively unusual within the medical cannabis clinic industry at the moment. Prescribing has to be safe and effective. We have to be prescribing the right products, but we also have to be mindful that a lot of the time these are Schedule 8 medications, and we need to be prescribing quantities of these that are appropriate for the needs of the patient, and not issuing 12 repeats on an initial consultation. This also happens quite commonly within this industry. I believe that patients should have access to continuous support. So, just because I'm a doctor doing this one day a week doesn't mean that any query from a patient can wait until that one day a week that I'm doing that. We have to have a system by which we can offer that support on a more continuous basis. And then there needs to be strong clinical governance within that. We need to be auditing our practice. We need to be looking at our outcomes. We need to be having a clinical governance framework that you'd have in any other kind of general practice or specialist clinic. And I put in here ethical practice as well. I strongly believe that we have to be prescribing the products that are appropriate for that patient. I've seen a lot of clinics that may stock one or two different brands, and if the patient doesn't want that, the patient's discharged and told to make their own arrangements elsewhere. I think there are also examples of situations where the doctor is directly or indirectly incentivized for prescribing particular products. And that's something I'm strongly against. I think we need to have a firewall there between your healthcare provider as someone that's providing expertise and advice, and someone else who's then supplying that medication. And I think that we get into dangerous territory when we blur those areas. APRA is very clear on that, that as a prescriber, if you have a vested financial interest in the medication that you're prescribing, you need to declare it at the time of prescribing it. I think a lot of clinics, you see this buried in the small print in page 9 of the consent form that kind of no one reads. And so I think I'm very, very clear that we don't have those kind of arrangements in the clinic. So that's what I'm thinking about quality. Affordability is it's a complicated process. It requires quite a lot of time. And so the way that we came around this is by looking at segmentation. I make the distinction here between segmentation and fragmentation. Segmentation of care involves a team approach with everyone in the team having a defined role in that patient's journey. Fragmentation is where everybody's working at odds with each other in an uncoordinated way. And look, I believe the way of providing a quality service, which is done at you can provide at a reasonable cost point, is through segmenting care. And this is how we do this. We have as many support staff in Can I Help as we have doctors at the moment. We have 15 doctors working in our clinic. We have 8 nurses and 7 administrative staff. And every team has their defined role within the patient journey. So our nurses do initial patient screening to make sure the patient's suitable. They do a very comprehensive pre-assessment. The doctor can then focus on co-creating that management plan, taking informed consent from the patient and issuing a prescription. And the nurses then provide that ongoing support with TG applications, helping with titration, acting as an ongoing source of contact throughout the patient's journey. They manage the formulary, they produce the clinic letters and manage the correspondence. And our admin team do all of the bookings, payments, administer the outcome questionnaires, chase up the consent forms, help manage the clinical system. And through doing that, I believe we're able to achieve a very high quality in terms of the care we achieve, but minimizing the amount of time the doctor spends on it through delegating those tasks that can be done more effectively by other members of the team. The third principle there is, before I move on, I just mentioned the other big thing with affordability is obviously not just the clinic fees, but the cost of acquiring the product. And so at Can I Help, we've partnered with MedCan Australia, and we operate a compassionate access scheme where eligible patients can get subsidies towards the cost of their medication. I mention that here because that's not just something that's open to Can I Help, that's open to any prescriber in Australia. And I've just put the website there, compassionateaccess.com.au. If you go on there, you can, patients can self-check their eligibility and see what kind of subsidy they get. There's also links there for prescribers who want to register for that scheme to prescribe those products with the discounts for their patients. So a bit of a mention for that. And the maximum discount there is 50%, and that's usually for patients with palliative care needs. But obviously that can be a huge difference. That can be the difference between receiving treatment and not receiving treatment. So that's something else we've been working on. The third thing of those was about how to provide accessible care. And I think one of the challenges we've got here with medical cannabis is all of our patients that respond become long-term patients. So if you're an orthopedic surgeon, or a patient joins your service, they have their operation, they recover, they're discharged, and that episode is finished. But with cannabis, the episode is never finished. The patients require long-term follow-up. And so what we see happens, you may have a lot of appointment availability to begin with, but as more and more patients join and require follow-up, we tend to see doctors fill up. And so in essence, if you're going to continue to take on new patients, you need to be expanding your appointment capacity continuously. The way that we've done that at Can I Help is, rather than investing in bricks and mortar clinics, we partner with doctors working everywhere. So doctors can do telehealth from home, or they can work from their own premises where they normally practice, and we essentially block out some of their time to work for us. And in doing that, we've been able to expand from 1 doctor to 15 doctors within the course of a year. And we've got physical locations where patients can go for face-to-face care across 4 different states and in 8 different locations. So I think in working in that way, we've been able to provide a clinic with kind of elastic walls, which has enabled us to grow. So we still maintain pretty good access. Our patients can get in with one of our nurses within a few days, and usually within a week or two with our doctors, which that's something that we're very proud of. So looking in summary, there are multiple logistical things that make cannabis prescribing within a routine general practice environment quite difficult. My view is that in designing a service here, it's that focus on quality, affordability, accessibility, and that was the starting point. And I'm a big fan of segmenting processes and trying to improve efficiencies as a way of navigating and getting around that. Very happy to take any questions or any comments or anything anyone would like to discuss.
Have you found any other companies coming on board with subsidies?
So yeah, there are definitely a number of subsidy schemes. They're all run in slightly different ways. So there are some companies that are offering an introductory discount, so half price on your first scripts, which I think is great. But then if the patient buys it and it really benefits from it and then can't afford to continue the therapy, that's not such a great thing. There's some other companies out there are running a specific range of products which are accessible to people with concession cards. And I was never particularly comfortable with the idea that that someone on a concession card, gets a discount, but it's on a limited subset of the products. My view was very much that someone's financial circumstances shouldn't really dictate the choice of product that's being made. So I've not come across any that are quite like the one we're doing with MedCan, but look, there certainly are other subsidy schemes out there, and I'm sure if you go around the trade stands, everyone will be kind of keen to tell you what they're doing in that area.
What's been your experience with interchangeable products within each category? Have you found that it's reasonably on par?
Yeah, I think when the TGA decided to do approvals by category rather than by specific product, that was a big step forward in opening up choice. As a prescriber, I'm not a fan of the kind of open prescription at all. I think that when you write a generic prescription, you're specifying the CBD and the THC concentration or the range. And I think, what we know is that the terpenes and the minor cannabinoids and these other components of the plant are so important in determining the therapeutic benefit. So I'm not very comfortable with prescribing generically. I prefer to prescribe a product that I know exactly what's in it. I also prefer supply companies when they can guarantee a good consistency from one batch to the next. I like to have control of that and review how the patient's doing, and then if they're not proceeding as we hope, then looking to change. But I'm a little bit wary of just prescribing, giving a very open prescription and letting the patient or the pharmacist choose. Maybe that's just a slightly controlling nature I have, but I think perhaps it's gone a little bit too far in that direction. Yeah, no, so great question, thank you. In terms of our follow-up, so we typically, our pathway would be they have their consultation with their nurse, they then have their initial consultation with one of our doctors. As a general rule, we'd follow them up with the nurse in 2 weeks and then with the doctor every month for 3 months, and then every 3 months after that. Obviously, that's down at the discretion of the prescriber, and we have some patients that might have transferred to us from another clinic who don't require such stringent follow-up, and we certainly have other patients who are ringing our nursing team every week with a query of one sort and the other, so there's a lot of variability. In terms of the impact of COVID on this, there's nothing that would have stopped us doing this beforehand, but what I think COVID has done is it's made telehealth as a method of consulting. It's really brought it from the periphery into the front and center. And I think that it would have probably been very difficult before COVID to say we're going to run a clinic that operates with a significant amount of telehealth, because I think people would have, you know, questioned the practicalities of running that. They'd have questioned the quality of care that you could have delivered by that, and patients may have found it less acceptable. But COVID has just brought that into the normal scope of practice. And so I think, you know, it's been one of the positive side effects of COVID in that it's helped us work with this model.
What's the likelihood any of this medication will be covered by health insurance companies?
So there are a couple of health insurance companies that are starting to cover this. A lot of health care companies have a clause within their within the thing that if there's a medicine that's not covered by the PBS, that they'll subsidise some of the costs. It's down to whether that healthcare company considers it a medicine or not, and that's where. But there are certainly a couple of healthcare funds that will partially cover the cost of this. I think in terms of it being globally covered on the PBS or by multiple things, I suspect we're still a number of years away from that, unfortunately.
Yeah, just a quick question around looking what you've historically done with treatments in the past. Thank you. Just looking at historical treatments in the past, is medicinal cannabis now as a class, is that something that you go to first on your own mindset? Is it instead of going with an SSRI, for instance, and then figuring that doesn't work, let's try this, is it now front of mind that you would use medicinal cannabis for whatever formulation it is you choose? But yeah, just out of interest.
Yeah, so we're not allowed to use it first line at the moment. One of the TGA criteria is we have to demonstrate that the patient has failed on a licensed therapy. So yeah, look, it's not, we're not using it as a first line therapy. My personal opinion, particularly CBD, is that I actually think it works in a way that's probably superior to a lot of SSRIs and is freer from side effects. So I would love to be in a position where I could do that, but you know, that's not the legislative framework we're in at the moment. So
yep.
I think what we require is some CBD products to be given license and you know, and to be on the register, and then like in those circumstances, I certainly would look at using that first line.
They refuse to try any medicines and they want to try cannabis first. And I'll just write to the TGA on my SAS application, patient refused to try any other medications. They want to try this first. And I've never had a problem getting it approved so far.
I've had a couple of experiences that are similar to that, where there's not really been a valid medical reason not to try anything else. But the patient's been adamant, and I've taken that exact same approach that you have, and that I'll write to the TGA, I'll be completely honest and explicit about the situation in the application I do. I personally think that a lot of my applications are read by a robot, because they're approved very, very quickly. And I've had experiences where I've submitted them at 9 o'clock at night and they've been approved by 5 in the morning. And I don't imagine the TGA is running a 24/7 service there. So were they? So yeah, so you know, I take that pragmatic approach as well. I think the important thing is that you've obviously got the approval through from the TGA. I'm an authorized prescriber. My authorized prescriber approval says that I can't use that as a first line. But if the TGA are willing to approve it, or their robots are, then you know, I'm fine with that.
Feedback with regards to mention maybe the importance of some of these other compounds in cannabis like terpenes. Are you seeing much patient feedback, whether they prefer full spectrum or are the isolates just as effective?
Look, my view on that is that the full spectrum products are definitely more effective than the isolates. I've had a lot of patients that you know, only get a partial response or not a very good response to an isolate. If you put them on a full spectrum oil, they do better. Certainly when you're using whole flowers and an inhaled one, the terpene profile seems to be really important. You can see have 2 different strains of a flower that are identical in terms of their THC, but have totally different terpene profiles. And one of them will put somebody to sleep and the other will have an activating effect. So I think that, you know, we've got a basic understanding of which terpenes have which effects, but we're still so kind of early on in understanding how these different components interact with each other and how that entourage effects works, which I think it makes this just a really fascinating area of medicine to be in, and something that I enjoy. And I treat every one of my patients as a clinical trial with one person in it. You know, we do the questionnaires, we measure their outcomes, I follow them up closely, and we try and get something that works well for them. So yeah, in answer to your question, terpenes, massive effects. In terms of the minor cannabinoids, that's much harder to assess. It's often not very easy to get detailed information about the minor cannabinoids in the individual products or the concentrations of them. But patients are becoming more and more interested in that. And I often get asked for, which oil is going to be highest in the CBG and things like that. So it's, the patients are a very informed group, I find.